Good morning, clinical problem solvers, or good afternoon, depending on where you are. Good evening, even for some of you. It's Tuesday morning. It's Neurology Virtual Morning Report. We're very excited to discuss a neurology case with you this morning. And so that means we will need 2 volunteers to discuss that case, and hopefully somebody has a case as well to discuss, to present. So do we have any luck on that this morning? 2 volunteers and a case? Does anyone have a neurology case they'd like to present? Somebody must have a neurology case. Neurology is everywhere. And 2 volunteers to discuss that case. Anyone like to present a case? I know so there are some people waiting for a neurology match to come in the mail, the virtual mail next week. Might they have a neurology case? Not to name any names, but I see some future neurologists here. Anyone have a case? We can't do our thing without a case and without 2 volunteers. Anyone? We know somebody has a case, and we know 2 people will ultimately decide. It always happens, but it can take some time. All right, we'll sit in awkward silence. My stand-up comedy days are over. I can't entertain you unless there's a neurology case and 2 volunteers. All right, James. No case, great, but you want to discuss neurology is a weak link. You're in the right place. We're here to strengthen that link. James has courageously broken the awkward silence. Now James needs a co-discussant, and we do need someone to present a case. Hopefully somebody has a case. Don't worry if you think, oh, my case, it's not perfect. I don't remember every single detail. If it's a neurology case, it's no problem. We'll go through it. If you're thinking, oh, Jorge, do you have a case? Are you volunteering to discuss a case? Because we usually have for discussants, it'd be great to have one person identifying as a man and one as a woman. So we can, if you were volunteering to discuss, Jorge, we can have you do that next time. You don't have a complete case. Okay, we'll have you first up for next time. Can we have someone identifying as a woman to co-discuss with James? And then we still need a case. Somebody must have a neurology case they saw on their rotation. Neurology is everywhere. And again, it doesn't have to be perfect. If you're thinking, I have a case, I'm not sure I know all the words in English, that's okay. Hablamos español. We have people who speak Portuguese. Most languages we can get by. So one discussant to go along with James in a case, please, please, please. Anyone? 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 Never seen it get quite this drawn out. We won't have much time to discuss our case. Can we have someone else to great. Just like to listen and absorb, no problem. Yeah, if it's your first time here and you just want to observe, that's great. If it's your first time here and you're thinking, I'll give it a try, that's fine too. If you've been here in the background listening and you'd like to discuss a case with us, that would be fantastic. If you don't have a case, is Travis here today? He has sort of a case library. I don't see Travis. All right, let's focus on our discussant. Can we have a second discussant to work with James today? And I think Sukriti is hopefully going to help us find a case from Travis's archives. But it's great when people bring their own cases. It's great practice to present a case and hear some new perspectives on it. Anyone like to go along with James? Nobody? 42 of you? So we need just slightly less than 2% of you to volunteer. Would you do that? Anyone? Anyone? All right. Well, we prefer usually to have someone identifying as a man and someone identifying as a woman, but we can go along with just two whoever volunteers. It seems people are not that interested in volunteering this morning. So Jorge, you're on. And Sukriti, were you able to find a case by any chance in Travis's archive? Okay.
I found a case, but I think somebody's volunteered in the chat.
Okay, great. Rashan, you might have a case. Fantastic.
All right, so good morning, everyone. All right, so it's not, I'm trying to get the case information. There's a case practically I had probably like 2 years ago. All right, trying to get the presentation. But yes, I could actually give the information if that's okay.
Yeah, if you think, do you have a whole case sort of, you can give us the history and exam and whatever lab?
I can.
Fantastic, great. Sold. We'll give one last chance. We were hoping again for our discussant, someone to go along with James, to have someone identifying as a woman. Any last takers? Going once, going twice.
I mean, if you want to look like a neurology stud, comparatively against me, you'll probably do pretty well. So I guess that could be reassuring.
All right, looks like no volunteers, so apologies. We try to not have this be majority or all men discussants, but that's how it worked out today. So hopefully folks will enjoy seeing Rashan present his case and James and Jorge discuss, and then we'll be excited to volunteer next time. Actually, I'm not doing this next Tuesday, unfortunately, so you'll have 2 weeks to mull it over whether you'd like to join us next time. Okay. Rashan, James, and Jorge, would you like to introduce yourselves briefly, and then we'll get on with our case?
Yes, hello everyone. I'm sorry, I'm Jorge.
No, George, that's okay.
I'm from Colombia, and I'm applying to neurology in this match cycle, so yeah.
Fantastic, good news, hopefully coming in 10 days. Jorge, excited to hear where you land. Yeah, go ahead, Rashan, James.
All right, so I'm Rashan Hadman. I'm also from South America. I'm from Guyana, and I'm faculty at the St. George's University.
Fantastic, thanks for joining us. Great.
And I'm James. I'm a third-year medical student at Midwestern University in the United States, and interested in internal medicine and potentially cardiology, and most likely not neurology, but maybe this will change my mind.
All right, we'll see what we can do. And if you go into cardiology, trust me, you'll be seeing plenty of neurology to go along with it. Great. Well, Sukriti, we might have you sort of doing double duty scribing and teaching points if you can keep up, because I didn't see Priyanka, but if you see her, feel free to make her a co-host. Okay, Rashan, if you wouldn't mind giving us just the chief complaint, just the chief concern in as few words as possible for us to get our discussion started.
All right. So this is quite an easy case, but I guess the discussion will be more fruitful, right? So we have a 71-year-old male was referred to the general hospital for abnormal shaking for 1 day and generalized weakness for 1 day.
Great. Okay, so we'll stop there. Thank you for that presentation. So Jorge, what comes to mind when you hear this initial, you see this this chief concern come across your pager in a year, in a couple months, right? Or you see this on the top of a file folder in your clinic. What's running through your mind here?
So when you think about the age and abnormal shaking without thinking about the time evolution of the symptoms, well, you can think about tremor and the different classifications of tremor and trying to localize if it's a cerebellar tremor, if it's an intention, which is intention type tremor, if it's an essential tremor, but of course, without thinking about the evolution. And the other one will be a Parkinsonian tremor, which is a rest tremor. But when linking it with the evolution and the time frame, it's very acute or subacute. So I would think about probably medication-induced tremor. That could be one of the possibilities, or patients who are having any acute cerebrovascular accident. So things like that, metabolic things that can cause tremor in a patient with a history of diabetes, for example. So those are my first thoughts initially, or even patients with infectious disorders that can present with tremors.
Yeah, fantastic. So you were thinking about localization and time course, always a good place to start. And when we have a disorder of movement here, we're going to have to figure out what type of movement it is. And in that case, I'm sure that Rashan is going to be giving us more information about that. But just hearing shaking, as you said, it could be a tremor. There are other things it could be as well we'll think about. But then you zeroed in on the time course, which I think is important here. This is a pretty acute process, right? It's come on over a day or so. So we think about acute, as people know, I like to divide it into sudden, truly sudden, or hyperacute, and then just acute, which is fast but not instant. So this seems to be sort of in that second category. So sudden, we would think about vascular causes, toxic metabolic causes, a couple of other things I won't mention yet to give James a chance to let us know what he's thinking here. And then acute, as you said, if this is truly emerging and evolving over hours to days, we might think more about an infectious process and some other things too. So those are great buckets to start dropping things into. And what were your thoughts here, James? And then I'll give some thoughts as well.
So I don't have a really good schema for shaking, but for the generalized weakness, I start to kind of think of, a few things like potentially cardiac output being a player, or essentially also just mainly oxygen delivery to tissues causing a generalized weakness. So which could be cardiac output, or so maybe even like a congestive heart failure, but with the time course doesn't really line up with that. But then even things like an anemia, which also with the time course doesn't really line up. And then even potentially one thing that could line up is the actual ability to carry oxygen. So maybe if he happened to be sitting in a house with a bad heater all day, maybe like carbon monoxide poisoning, though I don't think that would cause the generalized shaking. But then also, as Jorge mentioned, some metabolic abnormalities, like and some things that can cause weakness are, changes in levels in calcium, magnesium, or even sodium and potassium. And those are a few buckets before I even start thinking about central nervous system problems.
Excuse me, fantastic, great thoughts, right? So our first branch point with any neurologic chief concern, chief complaint, right, is to ask, is this a neurologic disease causing this? Or is this a systemic process that's manifesting in neurologic symptoms? So those are some great thoughts, particularly with weakness, right? Because as a neurologist, if you say weakness, I'm thinking, is this a problem in the corticospinal tracts within the brain, brainstem, or spinal cord? Is this a problem in the peripheral nervous system, in the roots, in the plexuses, in the nerves? Is this a problem at the neuromuscular junction, or is this a problem in the muscle? But as you said, a patient who's anemic, or who has heart failure, or has a low oxygen saturation, or has a systemic infection would also feel weak, right? We sometimes refer to this as asthenia. The patient feels weak, but when you do actual direct muscle testing of their strength is full. They're just sort of generally have a feeling of weakness or asthenia. So good. So great thoughts from both of you, and just a few thoughts from my end. So abnormal shaking, what starts running through my mind is, what is this abnormal shaking? And we'll have to hear more details about it from Rashan in a moment. And ideally we would, in practice, see it, because when there's abnormal movements, I say a picture is worth 1,000 words, but a video is worth 10,000 words, right? When people consult me over email and say, I have this patient who's shaky, I say, show me a video if possible, because that shaking could be seizures, right? This patient could have had a seizure and had abnormal shaking. This patient could have a tremor, as Jorge mentioned, and that tremor has a huge differential diagnosis, which this turns out to be tremor. We'll walk down that pathway, but you mentioned some possibilities: cerebellar lesions, Parkinsonian tremor, all kinds of different ways you can get tremor. Also, to James's point, medical conditions that can cause tremor, hyperthyroidism, medications, etc. Abnormal shaking, again, is general, which is great that Rashan gave it to us in these general terms. Maybe the patient's calling it shaking, but it's more of a twitching. And is that a myoclonic jerk, where a limb is moving across a joint in a lightning fast kind of semiology? Or is this a muscle twitch itself without moving the joint, like a fasciculation, as we would see with a lower motor neuron problem? So when I hear that they are presenting to the hospital for this shaking, it does make me worry that this is a seizure, because as Jorge pointed out, it's pretty hard to get a sort of instant onset tremor. A cerebellar stroke could do that if it's unilateral. But so I'm wondering if that was a seizure. And then the generalized weakness preceding that for a day makes me wonder if there's some systemic process, be that infectious or renal failure or something that's causing a generalized feeling of weakness and then ultimately provoking this seizure. Or does the patient have a primary neurologic illness causing this seizure, if it turns out to be a seizure, right? Like meningitis or encephalitis, and they had sort of an infectious prodrome, and then that sort of culminated in a seizure leading them to present. So those are some initial thoughts, and we always like to spend a fair amount of time just on hearing the chief complain and sort of unpacking what's running through our mind, because that gives us some initial hypotheses as we hear the history. Maybe the shaking has stopped and we're just hearing a description now from the patient or the patient's family. And so we're going to want to hear more about whether this was on one side or both sides, whether the patient lost consciousness as they would in a seizure, whether they lost continence as they often do in a generalized seizure, and other aspects of that nature, and whether there are fevers, whether there's underlying systemic diseases. All of those things that are about to come out are going to help us sort of figure out what was this shaking, right? What was this weakness, and what other features are going to point us towards an etiology as we go forward. So great, Jorge, James, great discussion, and great initial one-liner for us to start thinking about, Rashan. And if you'd be able to give us the rest of the HPI, that would be fantastic.
All right, sorry about that. My sister just came. All right, so just continuing with the presentation. All right, so one point to note is actually that this patient had a speech impairment. So the history was just given from the nurse that was at the nursing home, right? So, all right, so the from the history, right, the nurse noted that this shaking was not the patient's first episode, right? She mentioned that she noticed that the shaking occurred, well, of course, it occurred overnight and it had increased in intensity. She mentioned that it would occur at rest and also during physical activity. She noticed oh, sorry, I just remember person typing.
No problem, go ahead, go ahead.
All right. She mentioned that the shaking would occur more in his upper limbs and it's not controlled. The shaking episodes would last for about 5 minutes. And the intensity would decrease and then it would increase after about every 15 minutes. All right. The associated symptoms that she noticed with the shaking, that the patient had 2 vomit episodes, which was void of blood, was just food material. She also noticed that he had increased urinary frequency. and he had an episode of fever overnight, which she actually wasn't able to give a specific temperature. The aggravating factors, she noticed that movement would cause the shaking to get worse. And relieving factors, she mentioned that he used specific medications in the past that would actually decrease the shaking, but the nurse at that time could not mention what was the specific drug.
Mm-hmm.
All right. Also to note, with the weakness part of the history, she mentioned that he had 3 consecutive readings of low blood pressure. Right? It was, oh, sorry, I didn't have the blood pressure reading here. Right? And well, yes. Yeah, that's what I have for the history.
Fantastic. Great. So that's very interesting information. I think you were up first last time, Jorge. So James, what are you thinking now that you have this additional information?
So now with the additional information, especially with the speech impairment, that and the low blood pressures, it makes me start thinking, potentially with the low blood pressures and the fever, that the infection may have caused a septic shock kind of situation that led to maybe a decreased perfusion to the brain that may have led to damage that potentially started propagating these. It makes me think less about Parkinson's, mostly just because usually in Parkinson's, the tremors or shaking usually gets better with movement opposed to at rest. And so then also with the vomiting, increased urinary output, I mean, it could just be related to the infection, like an enteritis or UTI, which obviously in elderly individuals, for some reason, the urinary system is kind of linked to the CNS. And so with the vomiting and the high urinary output, it could also have potentially propagated maybe electrolyte abnormality, or even he could have, some type of diabetes type picture. And since we don't know what medication he was taking, maybe if it happens to be insulin, he may be even hypoglycemic, which like DKA picture could cause abdominal pain and vomiting. So it's kind of I guess helping me to zoom in a little bit, but there's still a lot of what we were saying in the beginning really isn't ruled out at this point.
Yeah, great thoughts. So pick up on a couple of things. So it's still, actually, let me ask quickly, since you started with the speech impairment. Rashawn, you said the patient has a speech impairment. Is that new as part of this new presentation, or that's the patient has had a long-standing speech impairment that's not part of this?
Yes, the patient had that since he was small, since he was a child. Yes.
So not part of the acute. Okay, that's helpful to know.
Yes.
Okay, great. Thank you. That's helpful. So yeah, James, good thoughts here. We have a patient with a history of shaking, and as you astutely pointed out, this now is starting to sound like a tremor, isn't it? Because seizures shouldn't get worse with movement and go away with rest. They just strike at random in general, although they can be provoked by flashing lights or other things like that. But movement, in principle, should not provoke those. And why would they have sort of be kind of on and off in all of these different patterns if they were seizures and they're just sort of affecting the hands? So it does sound much more like tremor, doesn't it? And you made the astute point, and we'll talk a little bit more about tremor, that the Parkinsonian tremor, which if you told me I have a 71-year-old patient presenting with tremor, right? If this was the USMLE, the first thing that's running through your mind, right, is Parkinson's disease. But as you said, the tremor of Parkinson's is interesting. It's there at rest, usually the supination, pronation, so-called pill rolling tremor of the hand. And then as soon as the patient goes to do something, the tremor goes away. And that's the opposite of most other types of tremors. So this doesn't sound like a Parkinsonian tremor, despite the patient's age. And it sounds bilateral. And idiopathic Parkinson's disease, usually the tremor begins unilaterally and stays asymmetric throughout the course of the disease, even as it spreads bilaterally as the disease progresses. So it sounds like, as you mentioned, there was probably some underlying condition that had tremor as part of it, or maybe all of it. And then there seems to be some acute aggravation of that tremor that may be provoked by a systemic illness, as you said, with the fever and vomiting and urinary episodes and low blood pressure. So the question remains sort of what the tremor is and then what's causing it to get worse. And I agree with you that it sounds like there's a systemic process causing that to happen. James or Jorge, other thoughts on what this tremor could be? I know I'm focused on the neurology, but I'm not sure we've talked about tremor in our morning reports before. Any thoughts on how you would approach tremor in terms of a framework or a schema? And that's okay if not, I can tell you how I think about it. But any initial thoughts? You mentioned one, which is it better or worse at rest versus with action? That's a great point. Other aspects in thinking through tremor?
So there's also the frequency of the tremor. When it's faster, it's more of essential tremor. When it's slower, it's more of a Parkinsonian tremor. On the physical examination, if it's a tremor that increases when you're going to reach an objective, then it's more of an intentional tremor, which is more seen in cerebellar syndromes. And also initially when they were telling the case, I also thought about weakness, like weakness and tremor. Patients who are presenting with weakness, like for example, myasthenia gravis, they can present with shaking. And they were saying that it was something that was transitory. There was, or for example, it changed over time during the day. I don't remember if it was worse during the afternoon or it occurred overnight. So you could think that along the day it was, of course, this wouldn't be the case, but in male patients, myasthenia gravis occur later in life usually, and it's early in women. And apart from the physical exam, if it's unilateral, usually it's a Parkinsonian. If it's bilateral, it's not that likely. And also I was thinking about other atypical Parkinsonian syndromes in these patients who is having some dysautonomia signs, like for example, the hypertension. So it could be also some sort of atrophy of multiple systems or other of the, mainly that one, not CBD or PSP, because he's not presenting with any of those symptoms. But because of the history of shaking previously, and I agree in that we need to explore a little bit better the history to understand what kind of shaking is it, and probably what's the baseline tremor and the acute event that's just adding some of the symptoms to it.
Brilliant discussion of tremor, Jorge. Future neurologist, I like it. And I like also, just to be a little bit silly, we heard low blood pressure and urinary issues and vomiting, and James, who's thinking about being a future internist, is thinking about a systemic infection, and Jorge, the future neurologist, says, could this be dysautonomia due to a neurodegenerative condition? Right? So it shows our frames of reference, right, when we hear these symptoms of patients coming to me with low blood pressure, and the internist didn't have a reason. I think, oh, could this be a neurodegenerative disease, which, as you mentioned, like multiple systems atrophy, one of the so-called Parkinson's plus conditions, a rare condition with Parkinsonism, not Parkinson's disease, but tremor, bradykinesia, and rigidity, but with significant dysautonomia. So great thoughts. So when we think about tremor, some of it has to do with what we're going to observe on the exam, and we can sometimes get a sense from history. And to be honest, in real life, right, while we're taking the history of a patient with tremor, we're watching and observing the tremor and how it behaves when they're focused on it versus not focused on it, et cetera. But so in terms of the phenomenology, we want to understand the frequency, meaning how rapid is the tremor? Is it very fast? As you mentioned, essential tremor is usually relatively fast, whereas the Parkinsonian tremor is sort of a slower to moderate frequency. And we want to look at the amplitude of the tremor, and whether it's sort of very large amplitude tremor, as you can often see, for example, with cerebellar tremor, or whether it's a relatively small amplitude tremor, as you often see with Parkinson's disease, right? So we want to look at frequency and with amplitude. The other thing we want to look at is how the tremor behaves in three positions. We've talked about rest and action, and there's an intermediate position we want to look at as well, which is posture, right? So for example, the tremor of Parkinson's disease, one of the most common causes of tremor, I think something like 1% of the population over age 65 or 70, don't quote me on that, but very common disease, right? That tremor will be present at rest. And as soon as the patient goes to move, so if they put their hands out straight, or if they do finger to nose, the tremor goes away. Actually, in Parkinson's disease, you can often see what's called a re-emergent tremor, where when they keep the posture initially, the hands stop shaking, and then the tremor sort of comes back after a few seconds. So some patients will say, well, when I'm reading the newspaper, I notice the shaking, and people say, oh, shouldn't it be a rest tremor? Is that an action tremor? One of my mentors used to say, it's a tremor of repose. Don't think of it as a rest tremor, because when the patient goes to sleep, the tremor goes away. But if the patient is in repose, either at rest or in a sustained posture, the tremor will come back out. And then it should go away with action until it's sort of very advanced and severe. On the opposite extreme, we have essential tremor, used to be called benign essential tremor, but it's disabling, so it's not maybe as benign. And as you mentioned, that at least in its early stages, is generally absent at rest, sort of comes back out with posture, and then it's there with action as well. But with action, it's a kinetic tremor, meaning a tremor of movement, but not an intention tremor, which Jorge mentioned. So with the tremor of cerebellar disease, we see an intention tremor, meaning as the intention is more precise, the way I think about it, the tremor worsens. So with cerebellar disease, there's no tremor at rest, there's no tremor with posture. And then when the patient goes to do finger nose, the tremor exacerbates as it gets closer to the target, because the cerebellum is involved in the precision of movements. And as that ability to make precise movements breaks down, then the movement becomes more erratic. So if you looked at a cerebellar tremor in slow motion, at the nose, it's very erratic. And then during the trajectory where you don't need that much precision, it's not that erratic. And then when it gets to the finger again, it gets very erratic and usually perpendicular to the plane of intended movement. So that's a cerebellar tremor. Most common cause of tremor we probably see in neurology clinic is some medication, right? So many medications can cause tremor. SSRIs, anti-epileptics, tacrolimus causes a very coarse tremor. And so drug-induced tremors are very common. Other causes of tremor, that one of the rarest is the rubral tremor, rubral for the red nucleus in the midbrain. That's one of the rare tremors that's present at rest, with posture and with action. It's relatively uncommon, and it looks sort of Parkinsonian at rest, and then it looks sort of more almost cerebellar with action is how I think about it. And then with any movement disorder, we actually have to also consider functional movement disorders, what used to be called psychogenic movement disorders. And these are movement disorders that don't have a clear neurologic disease as their basis, but are categorized as functional neurologic disorders, meaning there's something wrong with the function of the brain, but it's not something wrong with the structure. And in general, these are manifestations of patients who have underlying psychiatric disease or part of conversion disorder, but not always. And this is a rapidly expanding field of people making new inroads into understanding functional tremor. Functional tremors generally, or functional movement disorders of any type, can be relatively abrupt in onset, which aside from cerebellar tremor is rare. They can often be somewhat inconsistent. So most of the tremors we've talked about, they follow a very specific pattern, whereas you might see the tremor. Sometimes it's there with rest and then it's not. Sometimes it's there with action. But again, none of this is perfect as far as sensitivity specificity, because the Parkinsonian tremor can be there at rest. And then when the patient looks at the hand or they put it in their pocket, it goes away, for example. You can look for entrainment on exam. So if a patient has a Parkinsonian tremor on one side, and then you ask them to do finger tapping on the other side, right? The Parkinsonian tremor is just on its own frequency, but if someone has a functional tremor, often that tremor will entrain in rhythm to the intentional contralateral task. So those are some signs that could, that so-called entrainment or inconsistency in amplitude, frequency, and position. But basically, frequency, amplitude, rest, posture, action, those are going to be the main features we're interested in. And so given that, here we have that I think Rashan said, I'm looking at the notes, but I think you said, Rashan, it's not really much present at rest, mostly with movement, or did I misunderstand you there?
Yes, well, that's the history that the nurse gave me at that specific moment. So just take that with a pinch of salt.
Take it with a pinch of salt, okay. So here we're not sure, but maybe Rashan is hinting to us, right, that hearing that it's worse with activity, worse with action would push us more towards sort of essential tremor versus a cerebellar tremor. And if this has been going on for a long time and is intermittent and aggravated by action, we'll soon learn probably if it's bilateral and he had some relief with medications, that might push us more towards an essential tremor type picture. And that tremor can be exacerbated by a systemic illness, which there may be some clues to here. Or does this patient have a broader neurodegenerative disorder, as Jorge said, that has tremor as one component of it, and the rest is sort of dysautonomia and other features part of a larger neurodegenerative picture, or is this dysautonomia due to a systemic infection, right, as James suggested, and we're just seeing the essential tremor exacerbating in that context? I think those are sort of our possibilities. Rashawn, why don't you tell us anything we should know about the past medical history? You can leave out if there's something in the past medical history that tells us what the tremor is, right? But anything else for past medical history, medications, family, social, allergies, etc.
All right, thank you. All right, so the past medical history, the patient was diagnosed with hypertension in 2001. The patient was diagnosed with unknown tremors in the year of 2000.
Okay.
Right. The family history, everyone in the family were healthy. There were no conditions indicated. Surgical history, nil also. Allergies, no known food or drug allergies. The current medication that the patient's on lisinopril, 10 milligrams per oral. And there was a medication that the nurse could not have mentioned to me at that specific moment.
Okay.
Right.
Good.
And that medication actually relieves the drug. But I'll be able to mention it later in the vignette.
Very good. Very good, Rashawn. Good. James, Jorge, any thoughts here based on what the additional information, and then we'll hear the exam.
So, I mean, not taking the other drug into account, potentially obviously has the history of the hypertension and taking lisinopril for that. And so that could have potentially led to a low blood pressure that caused, a hyperperfusion problem. But even if he has had this chronic hypertension problem, depending on, lisinopril 10 is kind of a lower dose for hypertension. I mean, it may well control it, but maybe potentially having some kind of microinfarcts that are leading to some CNS dysfunction. So he obviously has the history of the speech impairment. So he could even have some kind of vascular territories that are leading to, either affecting somewhere in the substantia nigra or basal ganglia somewhere that are leading to this shaking problem.
Yeah, good thoughts. So he has hypertension, he's on lisinopril, right? So if he's, maybe this is good for his hypertension generally, but if he has a systemic infection brewing, right, it might be too much blood pressure control if something else is causing him to loosen his vasomotor tone, right? And he's periseptic, well, as you mentioned earlier. If there had been no tremor before, and this was a presentation of acute weakness and tremulousness, you might wonder, right, as you said, an infarct somewhere, either due to watershed, so-called border zone infarcts, right, from hypotension, or some other cause here if the patient's septic, has endocarditis, and had small infarcts. And that brings me back to a point that Jorge mentioned earlier, which I forgot to comment on, which was an excellent point, is that, as I mentioned first, right, if it's a neurologic presentation, we have to decide, is it a neurologic disease or a neurologic symptom triggered by a systemic process? And similarly with tremor, we have to determine if it's a neurologic disease or triggered by a systemic process. And Jorge mentioned a subtlety there, that if a patient's very weak, they can appear ataxic or tremulous just because of weakness. If you are doing heavy exercise, right, you lift a weight that's too heavy for you or something, right, your muscles get very shaky. Well, now imagine that there's baseline weakness, right? And the patients are trying to hold their arms up and they're a little bit shaky there. So if this tremor and weakness were all new, we could wonder, is this sort of true tremulousness as an independent process, or weakness causing some tremulousness? Good. I have some other thoughts here based on the clues of unknown things that Rashawn gave us, but let's see how we are with the time. We started a little bit late, so let's keep going, I'd say. So I guess the other thing to think about is, this was a tremor that we said the phenomenology anyway, that it's worse with activity, it's sort of intermittent. aggravated by movement, has been there for many years without the emergence of other features, at least as far as we've heard. Bradykinesia, rigidity, gait difficulties, things to push us towards Parkinsonism are not present. So this makes us wonder about whether this is essential tremor, as we've talked about, a tremor that is generally inherited, but some people, their parents die at younger age, and so they don't know if their parents were old enough to sort of develop this tremor. It sort of just emerges a little bit later in life for most people. So that time course would fit the phenomenology of it being worse with movement and less so, or maybe not even at all with rest. And then what could that medication have been? Do either of you know, Jorge or James, what medications are used for essential tremor and how they might figure into this case a little bit?
Yeah, they could use beta blockers or like, for example, propranolol. They could use primidone also sometimes. And they can go down other lines of medications, including topiramate, that is also useful for that.
Great, yeah, perfect. So first line is propranolol, beta blocker, or primidone, which is a barbiturate. So obviously both have risks, right? Propranolol can cause some hypotension, can cause some bradycardia, can cause so-called chronotropic incompetence, right, where the patient can't mount the heart rate they need when they stand up or exercise, so they could get orthostatic from that. And primidone as a barbiturate is very sedating. So two sort of suboptimal options. We'll often try low dose of propranolol. As you said, there are other things that have less evidence, but people can try topiramate, things like that. And then in the severest cases, even deep brain stimulation can be considered. So, and then you may have read, and this is often on USMLE questions, that essential tremor gets better when the patient drinks alcohol, right? That's actually not a perfect marker, because that can probably also alleviate that many tremors get worse with anxiousness, anxiety, right? So if alcohol loosens someone's anxiety, then it can be sort of a non-specific diminisher of tremor, right? And this is also, some patients don't drink, or they drink so little that it wouldn't have an effect. So that's another little piece of history sometimes you can pick up, but it's hard to know what to do with it. And so barbiturate's another sedating agent, as we mentioned, can do this as well. So I have to wonder if this unknown medication, right, was propranolol, and so maybe the patient is on some lisinopril and some propranolol, and having both of these together in the setting of what sounds like an emergent infection has predisposed them to hypotension. So that's one way we could try to wrap all of this together: essential tremor on a beta blocker, on an ACE inhibitor as well, and then a systemic infection aggravating the infection and causing him to have this picture, almost looking, as James said, sort of periseptic, but maybe these low blood pressures are because not just of the systemic infection and inflammation, but because he's got these two agents on board. Okay, what did you find when you examined this patient, Rashan?
All right, so let's go straight into examination. All right, so vitals. All right, so the blood in the emergency department, the blood pressure was 110/60, but on the ward, it was a blood pressure 130/70. Right, the pulse was 96, respiratory rate was 22, temperature 96 Fahrenheit, finger stick was 85, and O2 sat was 99. All right.
Mm-hmm.
So on general physical examination, the patient appeared alert, oriented, and cooperative. Patient was in no respiratory distress. The patient was afebrile and icteric. All right, so we're going into, all right, so from skin, HENT, cardiovascular, straight down to abdomen was normal, right, within normal limits, right? So let's go straight to the neuro. All right, let me see if I could actually show the video before. Let me see if I could get this camera switched. Sorry, I have it on my iPad. Let me see if I can somehow, oh, sorry. Great. Great, so I don't know if you could see this properly. Sorry, I had it in a PowerPoint.
No problem. So Jorge and James, just talk us through your observations here. It doesn't have to be technical terminology. How would you describe what you're seeing?
So it looks to be pretty rhythmic, I'd say. Is that his hand on the other side when he starts to move it? It looks like the tremor is kind of going away. It's hard to kind of tell.
Yeah.
Yeah, so, and it seems like he's in like a flex position, but I don't know whether you call that a quick or a slow tremor. I don't really have a good frame of reference to what would be considered slower or faster.
Yeah, great thoughts. What are you seeing here, Jorge? If you don't mind, just let it keep playing there, Rashawn. That's great. Just sort of let it.
Oh, you want? Oh,
if you don't
okay, let
mind.
me play it back. Sorry.
Nope. If you have to turn your camera off, also that's fine too.
No, that's okay.
What did you think of this, Jorge?
I think it's a very high amplitude movement, and it's a slow. I would consider it slow and high amplitude, not too fast, and it's very proximal. Like and when like it's not the wrists, it's not the fingers, not the distal. It's mainly located in the elbows. The movement is like the pivot of the movement, and it definitely stops with purposeful actions. So that would kind of rule out an essential tremor, and this is definitely not a Parkinsonian tremor because of a high amplitude that it has, and it is generalized. So even though it has a pattern that is very rhythmic for me, I would lean towards thinking about a functional neurological disorder. But we still have to ask more questions.
Yeah, so very interesting video. Rashawn gave us some clues earlier on that the history we were getting might not actually correlate with the exam. So very well done to have us discussing many things here. That's great. So I agree with you. This is a tremor that looked very prominent at rest, right? And we couldn't see the patient's hand, but when he reached out of the frame, we could tell at least that arm had really stopped moving, right? You noticed it was bilateral, but the hands are sort of going at different frequencies, right? And that's very common with tremors of neurologic disease, as opposed to functional disease where they're often entrained, as we said before. So this looked like a rest tremor that for as relatively moderate to high amplitude, and I would say moderate frequency, although these are subjective, right, disappears completely with action, right? So that's pretty characteristic of a Parkinsonian tremor. You might have noticed also there was left leg tremor there, but no right leg tremor that I could see. And that asymmetry also is suggestive to me of a Parkinsonian tremor. There was a sense to me that there was on the right arm a sort of supination, pronation type tremor. Usually the tremor of essential tremor, this is another little sort of very kind of nuanced or gourmet neurology pro, right? The essential tremor is usually flexion, extension, whereas the Parkinsonian tremor is generally supination, pronation, and the left hand was moving so much it was hard to tell, but the right hand did look to me to be in supination, pronation. So we couldn't see the patient's face. That would have been telling. Why do I say it? Obviously, Rashawn withheld that for patient confidentiality, which I appreciate. But if the patient had a mask-like face, right, with what we call hypomimia, decreased facial expression, decreased blink rate, those would be clues to a Parkinsonian disorder, right? If we saw, and then one thing I didn't mention earlier, I realized I forgot, we talked about amplitude, frequency, positionality. We didn't talk about distribution, right? So Parkinson's tremor tends to affect the hands first, can also affect the legs, can also affect the jaw with a little bit of jaw tremor. That one's harder to imitate. Whereas essential tremor often affects the head. You can get either sort of a side to side or a yes tremor or a no tremor. Often the patient doesn't even realize that they're doing that. Other people notice, but you shouldn't see that in Parkinson's disease. So if we saw the patient's head and there was maybe a little jaw tremor, it can often be very, very subtle jaw tremor. if we saw the sort of mask-like face of Parkinson's disease, those would be further supportive clues. Whereas if we saw a head tremor kind of side to side, no or yes, those are more common with essential tremor. So I neglected to mention the distribution. And the hands, it would be really hard, you'd be hard pressed to say whether there's any asymmetry there, but the legs, like I said, looked like there was some asymmetry. So we should go back to first impressions, right? We said we heard a 70-year-old person with a tremor, right? You might, your first impulse might be to think of Parkinson's disease. And if this truly started 10 years ago, or no, usually you say 2001, not 10 years ago, if the tremor started 10 years ago, then maybe it started on one side and was more the classic kind of sort of lower amplitude tremor, and then as it got worse over time, is now bilateral, involving the leg. And maybe that medication was not propranolol, but it was carbidopa, levodopa, or trade name Sinemet, or some other medication for Parkinson's disease, of which there are many. So I think based on our analysis of this being a rest predominant tremor, some asymmetry, at least in the legs, and a supination, pronation semiology, that this looks to me more like a Parkinsonian tremor, and a quite severe and uncontrolled one should make us wonder about the patient's medication regimen, and maybe we might want to tweak that to try to relieve this a bit. And then, Rashawn, anything else on the exam as far as any weakness or changes in the reflexes, anything like that?
All right, good. So so when we were examining the motor, the power was 5 out, grade 5 in all 4 limbs. The tone, the patient was rigid after the tremors for about 10 minutes. The reflexes was 2+ reflexes. In all the elicited reflexes, the coordination, the patient was not able to elicit any finger to nose due to the tremors. The gait, there was periodic increase and decrease, speed of movement, and loss of balance noted. The sensory was intact for pain, position, and vibration. And that was it, at least for the information that I had noted at that period.
Fantastic. Great, Rashawn. Fantastic presentation. We'll stop there for a moment. We've been going back and forth, I think, with almost all of these, Jorge and James. So whoever wants to speak first, do those additional features help at all here? Or?
All right, so I just mentioned some quick before. All right, so at the time while we were doing the physical examination, we were able to get the other medication. It was Cogentin.
It was Cogentin.
Yes.
Which is, I believe, benztropine. Is that right?
Yes.
Generic name. Yeah. Interesting. Okay. James and Jorge, what are your thoughts here? We'll wrap up.
Well, as you're saying, definitely, it's definitely more of a resting tremor, and more with the benztropine kind of gives it that it's a treatment for at least, and that's usually for. My impression was that typically they usually use like levodopa and for Parkinson's, which would make sense, I guess, in his context, since I know that typically over time when you use those drugs, they tend to kind of have different effects, and the dose adjusting has to be like adjusted more frequently, I guess, opposed to benztropine. I know that it's used a lot of times in Parkinsonian syndromes, like people that take antipsychotic medications to kind of reverse some of those what are they, akathisia. Oh, I can't pronounce it, but a lot of the adapt symptoms that come from those dopamine antipsychotics.
Fantastic. So we have Parkinsonism, right? That doesn't always mean we have Parkinson's disease, right? So there's a whole differential diagnosis for Parkinsonism, right? So there's the neurodegenerative side of that schema, right? Idiopathic Parkinson's disease, which tends to present later in life, tends to begin asymmetrically. And then, as Jorge mentioned, there are also the atypical Parkinson's or Parkinson's plus conditions that are neurodegenerative, multiple systems atrophy, dementia with Lewy bodies, corticobasal degeneration, and progressive supranuclear palsy that have Parkinsonism but have other features with each one. And vertical gaze palsy and early falls in PSP, dysautonomia and sometimes cerebellar features in MSA, and then unilateral cortical deficits and abnormal movements such as myoclonus, dystonia, alien hand syndrome, sensory deficits in corticobasal degeneration, and then dementia, hallucinations, and fluctuations in dementia with Lewy body. So that's the neurodegenerative side of Parkinson's, right? But there's also drug-induced Parkinson's. And the reason I'm thinking of that now is because cogentin is usually used to treat that rather than as a treatment for idiopathic Parkinson's disease, in my experience. So was this patient previous on antipsychotics or antiemetics, dopamine blocking agents that led to Parkinsonism? We've heard of tardive dyskinesia, right? James mentioned akathisia, which is sort of a restlessness. You can get tardive dystonia, tardive tremor, and you can also get this drug-induced Parkinsonism. I'm not sure if you can use benztropine. I believe it's an anticholinergic, though someone can correct me, just for Parkinsonian tremor. The anticholinergic we sometimes use in patients who just have tremor. They don't have too much bradykinesia. They don't have too much rigidity. We use trihexyphenidyl, which is an anticholinergic, which I'm not sure has any other uses outside of this context. But levodopa, dopamine replacement, is really good for reducing rigidity and reducing bradykinesia and helping with gait. It doesn't actually help with tremor that much. So if that's the main bothersome symptom, sometimes we try trihexyphenidyl, which is an anticholinergic, although we would avoid it probably in older patients because, as you know, anticholinergics can cause some altered mental status, dry mouth, etc. So I think for my final diagnosis anyway, I'm wondering, is this patient have Parkinson's disease, and it's exacerbated by whatever this presumed systemic process is, although here we're not hearing about a fever or a hypotension or any of these things that Rashan sort of tantalizingly gave us in the history, right? And so is this Parkinson's disease? Does this patient have a history we haven't heard yet of being previously on an antipsychotic or other dopamine blocking agent that led to a drug-induced Parkinson syndrome, Parkinsonian syndrome, that's being treated with cogentin, but unfortunately not that effectively here. So let us know what happened next, Rashan, and what you landed on for the final diagnosis for the patient's tremor and why it got worse and the patient came to the hospital.
All right. So I said, well, just for time's sake, I could mention for the values for the laboratory, everything came back normal, right? For the CBC, the urinalysis, the chemistry, right? No imaging was not done, right? When the consultant saw the patient, at the same time, one of the family members also came, and we were able to get the other medication. And well, not to anyone's surprise, the other medication was levodopa, carbidopa, right? So the patient was on one tab every 8 hours, right? So basically how the patient was managed, the patient was placed back on the medications, the levodopa, carbidopa. The patient was advised on their diet, and the patient was observed for I think was just for 2 more days. The patient was admitted to the hospital and then was able to return back to the nursing home, right? So the final diagnosis was actually Parkinson's disease, right? And I don't know could I mention something also?
Please.
All right, so just now you were talking about the same Parkinson-like syndromes, right? So this was a great teaching point where actually you could mention about the Parkinson plus syndromes, where, it tends to affect mostly like the basal ganglia and could lead to the other system being affected. So we could think about like the Schreck-Drager. We know that the patient would have like an autonomic dysfunction, and they could also present with the cerebellar and the pyramidal signs. They would also tend to have more rigidity, more than the tremors. There's also the progressive supranuclear palsy, where we know the patient could have also postural symptoms, right? And could be contributed due to like falls. They could also have a speech disturbance, but we noticed from this patient history, they had a speech impairment since they were small. The patient, their palsy, they would tend to have more vertical gaze. Yes, and that's my contribution to this case.
Fantastic, Rashawn. Great case, and also presented very beautifully, because as you hinted to us, there were ways that the diagnosis could have been apparent from the beginning, and you really gave it to us in aliquots that helped us really think through so many interesting teaching points here. And from the Bayesian perspective, right, older person with history of tremor for 10 years, you're thinking about Parkinson's disease or essential tremor, and then looking at the tremor will give you the answer, but you presented this brilliantly so that we had some nice twists and turns. Just out of curiosity, was the patient's tremor so severe at hospitalization because the nursing home had stopped giving him the levodopa, carbidopa, or he had stopped taking it for some reason, or he was just on a low dose and that's what he looked like? Or what was the sort of worsening that brought him in, or this sort of fever and all that stuff was kind of just red herring, that the patient just had Parkinson's, was brought to the hospital, and then looked fine and was sent home?
Yes, so it was actually that the patient was not taking the medications, and the nurses on that shift also, they kind of panicked because they noticed that he had the low blood pressure and the tremors. So then he was referred.
Got it. So yeah, carbidopa, levodopa are given together as Sinemet in one pill. The levodopa is the dopa you want the dopamine to get into your brain for dopamine replacement, and the carbidopa blocks peripheral dopamine breakdown in the bloodstream. So the levodopa gets into the across the blood-brain barrier, and you don't get too much peripheral breakdown, causing the symptoms of nausea and queasiness that often go along with this. It's important to note that if a patient stops carbidopa, levodopa abruptly, or a dopamine agonist, such as pramipexole or ropinirole, abruptly, they can have essentially neuroleptic malignant syndrome. So you know that syndrome that can come from antipsychotics, from dopamine blockade. If the patient has gotten used to a certain level of dopamine and these medicines come off abruptly, either the patient stops taking them for some reason or the patient is ill and vomiting, you have to watch them very carefully. I've never seen this syndrome, and I've talked to movement disorders doctors who've also said it's extremely rare, because patients want to take this medicine because they feel so much better taking it. But you can get, very high CK, an elevated white count, a high fever, and it look like the patient's infected, or the patient may also be infected, and that's why they weren't taking their pills. And these patients can get very sick. They can become so rigid that they develop rhabdomyolysis and high CK, and then renal failure, et cetera. So it's sort of a dopamine withdrawal syndrome. So fortunately, that wasn't the case in this patient. His labs were normal. He was afebrile. His vitals were normal. But hopefully, when you got him back on his medication regimen, things looked a little better. So great case, allowed us to think through a framework for tremor and a differential diagnosis for Parkinsonism, and even thanks to James, talk about some internal medicine a little bit too. My weakness as a neurologist about all the medical things that could have been going on here. So brilliantly presented, Rashawn, and brilliantly discussed, Jorge and James. I know we're a little bit over time, but I will attribute that to delayed volunteerism today. So please think about whether you'd like to participate in 2 weeks if you have a case. As Rashawn showed us, it can be a case with a very very common diagnosis, right? And we can still have a rich discussion about it. So it doesn't have to be some rare mitochondrial disease or something. And hopefully you saw from Jorge and James, it's fun to just think through this together, no pressure, fun, safe space to talk about neurology. Great, Sukriti, do you want to take us home with some teaching points? I know people are dropping off as we've run over a little bit, but those who are here, I'm sure will be very interested to learn from your teaching points.
Thank you, Aaron, and thank you, Rashawn, for the case. So for the sake of time, I'll just keep this brief and go through some of the highlights as we discuss this case. So the first thing that we did was to investigate the symptom. And as we always do in Neuro VMRs, we use localization into time course to make progress. So this patient came with a sudden to acute onset, and just thinking about what buckets we need to consider. One is vascular, toxic, metabolic. And then as we go from sudden to acute, to also consider infectious processes. The second thing we did was to investigate the two chief complaints essentially. The first one was weakness. So our approach to weakness was essentially to identify whether this was a neurological weakness or was it a systemic weakness like an asthenia. And then the second thing to do was to map out the motor pathway. However, here we sort of used our cognitive energy more on the abnormal shaking to make progress. And so Aaron taught us today that shaking can be thought essentially in three buckets: seizures, tremors, and twitching. But we prioritize seizures because of the morbidity associated with it. But given this patient's age, here base rate favored the tremor of Parkinson's disease, and this was really what we came back to as we went through the case. The second part of our discussion essentially revolved around collecting clues, and here we framed an approach to tremor. So our illness scripts for tremor would possibly consist of these large categories. The first would be to identify whether this was really a tremor or was this weakness leading to tremulousness. The second is to account for the frequency, the third, the amplitude, the fourth, the position, and within position to think about rest, action, and what's in between, which is posture. The fifth thing to consider is the distribution. And here we found that hands, legs, and a jaw tremor would favor Parkinson's versus a side-to-side tremor that would favor essential tremor. And every illness script is incomplete without medication. So always think about things like SSRIs, tacrolimus that can cause tremor. And so Aaron laid down many illness scripts for tremor, but I think I'll just go through the highlights. So something I didn't know today was the nuances of distinguishing Parkinson's and essential tremor. For example, pronation supination tremor is usually a Parkinson's tremor versus a flexion extension of the essential tremor. A rubral tremor is a slow course tremor, and here when you think about position in this tremor, think about it resembling Parkinsonian tremor at rest and a cerebellar tremor with action. And the last category that we discussed was the functional tremor, which is associated with psychiatric disorders. It's abrupt, often inconsistent with rest and action, and has a positive entrainment test. So as we went through this case and framed the clinical syndrome, very early on, James identified that this case could essentially be two things. The first is it could be a primary neurologic process like meningitis or meningoencephalitis with an infectious prodrome that was leading to his weakness versus a systemic illness that was leading to his weakness, predisposing to his seizure. And then in this context, we discussed this patient's hypertension and also some of the symptoms of vomiting, the fever, the three consecutive readings of low blood pressure. And here we really highlighted the different contexts of thinking about these symptoms in terms of the dysautonomia that was associated with a neurological syndrome versus something like a sepsis or a systemic illness, inflammatory illness that was leading to these symptoms. And another thing that I learned today was how Aaron taught us that alcohol is actually a non-specific diminisher of essential tremor, contrary to what we've learned in a lot of our exams. And finally, we concluded this case by thinking about Parkinson's, and Parkinson's can essentially be thought of in three buckets: Parkinson's disease, which is idiopathic, versus Parkinsonian plus syndromes, versus medication-induced Parkinson's. And finally, Aaron taught us about the pearl about abrupt cessation of dopamine increasing medications like levodopa, carbidopa that can cause neuroleptic malignant syndrome.
Great, fantastic synthesis, Sukriti. And again, thanks so much, Rashan, for volunteering to present this case and for presenting it in such a way that allowed us to discuss so many of these teaching topics. And James and Jorge, thanks again so much for volunteering to discuss. Hopefully people saw how much fun we had. I won't be here next Tuesday. I'm not sure if there'll be a non-Neuro VMR. It'll just skip a week, but hopefully the following Tuesday, people will be excited to volunteer to present the case or discuss the presented case. So have a good Tuesday, everyone. Thanks again for joining us this morning.
Thank
You're
you.
welcome. Have a good day.
Thanks.
Thank you.